Welcome to the Step 2 High Yield Emergency Medicine section. My name is Niket Sonpal. I am the Chief Resident at Lenox Hill Hospital, North Shore LIJ Health System, and Assistant Clinical Professor at Touro College of Medicine. To start today's lecture, we're going to begin with toxicology, poisoning, and overdose. The USMLE loves to ask questions on this because it's a very simple cause and effect and treatment modality of questions. A 32-year-old female with a history of depression comes to the emergency room 30 minutes after ingesting a bottle of pills in an apparent suicide attempt. Her blood pressure on arrival is 118/70, her pulse is 90, her respirations are normal. She actually refuses to tell you what she took. What is the next best step in treating this patient? Is it A, induce emesis with ipecac, B, gastric lavage, C, psychiatric consultation, serum chemistries, E, urine toxicology, F, cathartics or laxatives, G, whole bowel irrigation, H, to administer naloxone, or I, to administer flumazenil? The correct answer here is actually B, gastric lavage. The reason why A is incorrect is when ingestion is extremely recent, it is possible to try and remove the substance from the body prior to its absorption. Gastric emptying has very limited value because there's not much time between the ingestion and passage of the pills beyond the pyloric sphincter from where they cannot be removed. Pills on an empty stomach can leave in as little as 30 to 60 minutes. Therefore, gastric lavage can be attempted up to 2 hours after ingestion, but it will remove only about 50% of the pills at 1 hour and only 15% at 2 hours. After 2 hours, it is completely useless. Now, going through each of the choices, although serum chemistry and urine toxicology screens should be done, they are not helpful this soon after the ingestion. Ipecac and the induction of vomiting is wrong when a patient is already in the emergency department. Inducing vomiting needs 15 to 20 minutes to work and only delays the administration of antidotes such as N-acetylcysteine, which can be given orally. Like I said, inducing emesis can cause caustic injury if you don't know what she consumed. A psychiatric consultation is always wrong because any consultation is always 99% the wrong choice on the USMLE. Serum chemistry, it takes too long and it's too soon after ingestion to show any differences. Urine toxicology, it won't show up yet because the pills have not been ingested and metabolized. Cathartics and laxatives take too long and they haven't really made the transit time to the colon. Whole bowel irrigation, same reason why cathartics and laxatives won't work. The pills have not made it yet to the colon. Naloxone won't work because we don't know if it's an opiate, and flumazenil is not indicated because we don't know if it's a benzo. The best step, and I repeat, the best step after ingesting an unknown chemical and knowing how soon after is gastric lavage. There are 5 major treatments for somebody who presents to you with overdose. The first is gastric lavage. The second is to administer a cathartic agent. The third is to administer ipecac, which forces vomiting. The fourth is to give high-volume fluids and then subsequent diuresis. And the last is to do whole bowel irrigation. The initial steps in managing a poisoning patient involve gastrointestinal emptying, specifically gastric lavage. Gastric lavage may be useful in the first hour of ingestion, however, it is dangerous in 2 settings. The first setting is when there is a caustic ingestion. Ingesting of a caustic acid or alkali contraindicates using gastric lavage because when you bring those chemicals back up, you might actually cause burning of the esophagus and oropharynx. The other time gastric lavage is contraindicated is in a patient with altered mental status. When you do a gastric lavage in this case, the patient cannot protect their airway, and therefore they may aspirate stomach contents, leading to a pneumonitis or aspiration pneumonia. What should be kept in mind during the exam is that gastric lavage is rarely done. The reason for that is that it only removes about 50% of pills at the 1 hour mark and only 15% of the pills at 2 hours. Therefore, its yield is very, very poor. However, it is still done on some rare occasions. One tip for you to keep in mind during exam is if they ever give you the choice of Ipecac, it is always the wrong answer in the emergency room. If you're presented with a question in which the mother is calling you at home as an outpatient consult, the first thing you want to tell her is get the child to the ED, but remember, it is always the wrong answer in the emergency room. Although Ipecac has been used as a home remedy in those with accidental overdose or pill ingestion prior to coming to the hospital, there is no benefit in using Ipecac as an inpatient. Ipecac requires 15 to 20 minutes of onset and actually delays the administration of other antidotes. Cathartic agents such as sorbitol are always the wrong answer on the USMLE. Prokinetic agents such as metoclopramide and erythromycin are also the wrong answer. Speeding up gastrointestinal transit time does not eliminate the ingestion without absorption factor in a poisoned patient. Giving fluids and diuretics to accelerate urinary excretion is always a wrong answer. More patients are actually harmed because of the large volume intravascular expansion and develop pulmonary edema rather than being benefited by the forced diuresis. Placing a gastric tube and flushing out the GI tract with polyethylene glycol such as Go-Lightly is almost always the wrong answer. This is the same chemical they use to clean out the bowel prior to a colonoscopy. The only time this is correct, and the indications are very narrow and limited to massive iron ingestion, lithium, and drug-filled packets such as those who are trying to smuggle cocaine in their bum. Say, for example, you're presented with a patient, like earlier in today's slides, that was unclear as to what was ingested. And if they ask you what is the most likely cause of overdose, in the United States, the most common cause is acetaminophen. The second most common ingestion is aspirin. If you're questioned and not sure what to do, what is useless or dangerous is always very clear. That is Ipecac, forced diuresis, and cathartics. You can always rule these three out from the answer choices. If you get these three, you're only left with two choices. Now you've got a 50-50 chance to get the question right. Remember, knowledge is power in this case. A woman presents to your emergency room 1 hour after taking a bottle of pills. Her blood pressure is 118/70, her pulse is 90, her respirations are 14. She is confused, disoriented, and lethargic. What is the next best step in the management of this patient? Is it A, to give flumazenil, B, to perform a gastric lavage, C, psychiatric consultation, D, administer naloxone and dextrose, or E, intubate the patient? The correct answer here is actually to administer naloxone and dextrose. The best initial management of anyone with altered mental status of unclear etiology is an opioid antagonist and glucose. Opioid ingestion and diabetes are extremely common. Naloxone and glucose work instantly and have no adverse effects. Therefore, it doesn't hurt to try. If they do not work and the patient is still lethargic, concern then raises about protecting the airway. Therefore, intubation should be conducted, possibly followed by gastric lavage. Intubation should not be done first, however. Naloxone is faster, and emergency intubation is associated with aspiration, trauma to teeth, and the possibility of intubating the esophagus. Flumazenil only reverses benzos, but can cause seizures from instant withdrawal. So again, flumazenil is the wrong answer because you can precipitate a seizure. Gastric lavage is dangerous in altered mental status, as we described earlier. Getting a consultation is never done. Remember, you are the MD. And intubation is not the first step. First administer naloxone and dextrose, then consider intubation. I cannot beleaguer this point enough, but psychiatric consultation is only indicated for suicide attempt, but it is always the wrong answer choice on USMLE Step 2 CK when specific antidotes and diagnostic tests are needed. Opioid overdose is fatal due to the risk of respiratory depression. Therefore, always give naloxone immediately. Contrastingly, benzodiazepine overdose by itself is not fatal, and acute withdrawal can cause seizures. Therefore, do not give flumazenil immediately. Charcoal is a benign substance and should be given to anyone with a suspected pill overdose. Charcoal may not be elective for every overdose, but it's not dangerous in anyone. Charcoal can also remove toxic substances even after they've been absorbed and are superior to lavage and ipecac. Blood levels of toxins actually drop faster in those given repeated doses of charcoal when compared to lavage and ipecac. When you don't know what to do in toxicology, give charcoal. What is interesting is that legal drugs kill more people in the United States than illegal drugs because they're less expensive and more available. Toxicity due to acetaminophen usually occurs with an ingestion of greater than 8 to 10 grams. Fatality due to acetaminophen occurs after an ingestion of greater than 12 to 15 grams. When it's mixed with alcohol, it actually decreases the amount of acetaminophen needed to cause toxicity. The USMLE loves acetaminophen overdose. The four most common acetaminophen overdose questions are as follows. Number one, if a clearly toxic amount of acetaminophen has been ingested, greater than 8 to 10 grams, what's your next best step? The next best step in this case is to give N-acetylcysteine. If they tell you the overdose was greater than 24 hours ago, unfortunately, at that time, the next best thing is no therapy at all. If you are told that the amount of ingestion of acetaminophen is unclear, the next best step for your patient is to get a drug level. If you're questioned about the interaction between charcoal and N-acetylcysteine, what you should know is charcoal isn't contraindicated with N-acetylcysteine. When you're presented with the question, what is the most likely diagnosis, and you're told that the patient ingested aspirin, the way to figure out that is the correct diagnosis is 1, look for tinnitus. Then, hyperventilation due to acidosis, respiratory alkalosis with a mixed metabolic acidotic picture, look for renal toxicity, altered mental status, and you'll have an increased anion gap. Aspirin, when ingested in lethal amounts, can cause a diffuse multisystem toxicity. It causes ARDS. It can also interfere with prothrombin production and raise the prothrombin time. It can also increase your partial thromboplastin time. It can cause a lactic acidosis. The way it does so is by interfering with oxidative phosphorylation that results in anaerobic glucose metabolism, which subsequently produces lactate. And lastly, it can produce respiratory failure. The key to treatment in aspirin overdose is alkalizing the urine, which increases the rate of aspirin excretion. You must know the blood gas in aspirin overdose. Why? Because tinnitus, respiratory alkalosis, and metabolic acidosis are the key to diagnosing aspirin overdose on the USMLE. Which of the following is the most likely to be found in aspirin overdose? As you can see here, there are 4 choices in the blood gas. The correct answer is C. The blood gas shows a respiratory alkalosis with a low PCO2 and a metabolic acidosis with decreased bicarbonate. Because the pH is alkalotic, we know that respiratory alkalosis is not simply compensation for a metabolic acidosis. Choice D is a primary metabolic acidosis with a respiratory alkalosis as compensation, as would occur in sepsis, DKA, or uremia. Choice B shows an increased PCO2 and an elevated bicarbonate. This represents a primary respiratory acidosis with bicarbonate retention at the kidney as compensation. This is actually characteristic of COPD. A patient with known depression presents with altered mental status from ingesting multiple toxic substances. You know for certain that he took some lorazepam only today for the first time. There was no response to naloxone or dextrose. The patient is given flumazenil and immediately seizes. What is the most likely cause of the seizure? Is it A, cocaine withdrawal, B, opiate withdrawal, C, tricyclic antidepressants, D, SSRIs, or E, aspirin? The correct answer is tricyclic antidepressants, C. It cannot be A, cocaine withdrawal, because cocaine toxicity causes seizures, not the withdrawal. It cannot be opiate withdrawal because that does not cause seizures. It cannot be SSRIs because SSRI toxicity causes serotonin syndrome. And lastly, it cannot be aspirin because it causes tinnitus, hyperventilation, but not seizures. You might be thinking, well, what if it's the flumazenil relating to the seizure from lorazepam use? Remember, he only took it today for the first time. The answer here is C, tricyclic antidepressants. What is the best initial test for the patient previously described? Is it A, a urine toxicology, B, an electroencephalogram, C, an EKG, D, a head CT, or E, a potassium level? In this patient, the next best step would have been to get an EKG. Urine toxicology, electroencephalogram take too long. A head CT does not show the etiology of a seizure. A potassium level isn't the underlying cause for the seizure. With tricyclic antidepressant toxicity, there is a rapidly detectable change on an EKG. The EKG will show widening of the QRS, which can then lead to fatal arrhythmias. Here's a rhythm strip of a patient with tricyclic antidepressant toxicity. Note the undulating amplitude. It looks like it's twisting around a point. This essentially happens because the QT prolongs until torsades develops. The findings with tricyclic antidepressant toxicity can cause seizures and arrhythmia that lead to death. The seizures are most notable. However, a wide QRS will tell you who is about to have an arrhythmia. The other findings, such as dry mouth, constipation, and urinary retention, are not going to cause death. These are just secondary to the anticholinergic effects of the tricyclic antidepressant. Now, how do you treat the patient with the tricyclic antidepressant toxicity? Well, the best initial treatment for a TCA overdose is with sodium bicarbonate. Bicarbonate will protect the heart against an arrhythmia. However, unlike with aspirin overdose, bicarbonate does not increase urinary excretion of TCAs. Caustic ingestion of acids and alkali, for example drain cleaner, causes mechanical damage to the oropharynx and can lead to esophageal and stomach perforation. Never give alkali chemicals to reverse the acid or give an acid to reverse alkali. Essentially, never try to balance them out. The reason for this is they could release a great deal of heat from the exothermic reaction that occurs when acids and bases come together, and you'll only make the situation worse. Remember, this is not the time for 7th grade chemistry. The mainstay of treatment for caustic ingestion is to flush out the caustics using water in high volumes. Endoscopy is later performed to assess the degree of damage. Remember, steroids don't prevent injury from caustic substances, and therefore is the wrong choice. Carbon monoxide poisoning is the most common cause of death in fires. 60% of deaths on the first day after a fire are from carbon monoxide poisoning. Look for in the history something mentioning about gas heaters or wood-burning stoves, automobile exhaust, particularly in an enclosed environment. Remember, thermal injury is always the wrong answer when asking for the most common cause of death from a fire. Carbon monoxide binds oxygen to hemoglobin so tightly that carboxyhemoglobin will not release oxygen to tissues. Carboxyhemoglobin acts functionally like anemia. Now, there is no functional difference between the absence of blood and carboxyhemoglobin. 60% of carboxyhemoglobin acts like the loss of 60% of your blood. Carbon monoxide poisoning presents with dyspnea, lightheadedness, confusion, seizures, and the cause of death from carbon monoxide poisoning is myocardial infarction. Carbon monoxide poisoning presents with functional anemia. Remember, 60% carboxyhemoglobin acts like the loss of 60% of your blood. The patient will experience shortness of breath and dyspnea. They'll feel like the room is spinning and lightheaded. They will be subsequently confused from lack of oxygen delivery. They may have a seizure, also due to lack of oxygen delivery to the brain. And ultimately, they'll die, again, from lack of oxygen delivery to the heart and experience a myocardial infarction. As I said, there's no functional difference between having carboxyhemoglobin floating around your body and actually hemorrhaging. Remember, 60% carboxyhemoglobin, your body thinks you just lost 60% of your blood volume. The left ventricle can't distinguish between anemia, carboxyhemoglobin, and stenosis of coronary arteries. Which of the following blood gas results would you expect in a person with carbon monoxide poisoning? Here are your choices. The correct answer is D. Choice A is a distractor because it's alkalotic, but remember, the tachypnea does not necessarily result in alkalosis. Choice B is wrong because that's a respiratory acidosis with metabolic alkalosis. Choice C is incorrect because that's showing a respiratory alkalosis with an underlying metabolic acidosis. Choice D is correct because you have an even pH. Carbon monoxide poisoning prevents oxygen release to tissues, so lactic acidosis develops. In carbon monoxide poisoning, the ABG is very misleading. Carbon monoxide poisoning gives a normal PO2. This is because oxygen doesn't detach from hemoglobin. The best diagnostic tests for someone with carbon monoxide poisoning are as follows. Pulse oximetry will be falsely normal and therefore not the best choice. The most accurate test is a level of carboxyhemoglobin. If you obtain an ABG, remember you're expecting to find a low bicarbonate, a low pH from metabolic acidosis. The best initial treatment for someone is to remove them from exposure and give them 100% oxygen, which forces carbon monoxide to detach from hemoglobin and shortens the half-life of carboxyhemoglobin itself. The mainstay of treatment for carbon monoxide poisoning is to remove them from the source of carbon monoxide and give them 100% oxygen. However, for patients with severe disease, the treatment is hyperbaric oxygen. Severe disease is defined as CNS symptoms, cardiac symptoms, or metabolic acidosis. Methemoglobin is oxidized hemoglobin locked into the ferric state. Remember, ferric is iron plus 3, and ferrous is iron plus 2. Oxidized hemoglobin is brown and will not carry oxygen. They love using the buzzword chocolate brown blood on the exam. Methemoglobinemia results from an idiosyncratic reaction of hemoglobin to certain drugs such as benzocaine and anesthetics, nitrites and nitroglycerin, dapsone. So if you take ferrous hemoglobin, the plus 2 form, expose the patient to either benzocaine, nitrites, or dapsone, it will result in methemoglobinemia, or the ferric state, iron plus 3. The effects of methemoglobinemia are similar to carboxyhemoglobin. Basically, oxygen is not delivered to the tissues, and what ends up resulting is a functional anemia, dyspnea with cyanosis, severe lightheadedness, confusion, seizures, headache, and metabolic acidosis. With carboxyhemoglobin, the oxygen is picked up, but will not release to the tissues. Severe symptoms arise when blood levels rise above 40 to 50%. In methemoglobinemia, however, hemoglobin will never pick up the oxygen. Therefore, symptoms begin right away. Remember, in either case, there is no functional difference for end organs such as the brain or the heart. Carbon monoxide blood will look abnormally red on presentation. Methemoglobinemia blood will look abnormally brown. Both methemoglobinemia and carboxyhemoglobin give a normal PO2 on the blood gas. There is no delivery of oxygen to the tissues. The most accurate test is a methemoglobin level. The best initial therapy is 100% oxygen. The most effective therapy is methylene blue, which decreases the half-life of methemoglobin. Remember, if you have cyanosis and a normal PO2, that is always methemoglobinemia. Organophosphate and nerve gas are identical in their effects. Nerve gas, however, is faster and more severe. On the USMLE, they love to present either a farmer or a soldier. Remember, the way these two chemicals work is by increasing acetylcholine in the synaptic cleft by inhibiting its metabolism. Organophosphate poisoning presents with polyuria, lacrimation, which means tearing of the eyes, salivation, bronchospasm, and bronchorrhea, which leads to a great deal of secretions, and lastly, respiratory arrest. Acetylcholine constricts the bronchi and increases bronchial secretions. This inhibits both ventilation and respiration. Without gas exchange, the patient will ultimately succumb to respiratory failure. A 56-year-old military commander is attacked with nerve gas. He presents with salivation, lacrimation, urination, and defecation with the feeling of shortness of breath. His pupils are constricted on exam. What is the first step in managing this patient? Is it A, administer atropine? Is it B, decontaminate and wash the patient? Is it C, remove all his clothing? Is it D, pralidoxime? Or is it E, no therapy is effective and simply do nothing? The correct answer here is actually A, atropine. Atropine blocks the effects of acetylcholine that is actually already in the body. Atropine dries up respiratory secretions. Now, removing clothes and washing the patient is good to prevent further absorption, but it will do nothing for the symptoms that are already occurring. And what about the acetylcholine that's already in his body? Pralidoxime is the specific antidote for organophosphates. However, this is not the case because he was attacked by nerve gas. Pralidoxime reactivates acetylcholinesterase and therefore breaks down acetylcholine in the synaptic cleft. However, it does not work as instantaneously as atropine. So to review, decontaminating the patient, you must stabilize first. Removing his clothing, stabilize first. Pralidoxime will take too long, and remember, no therapy is effective is never the right answer in managing this patient. As the last case illustrated, nerve gases and organophosphates are absorbed through the skin, and washing the patient for decontamination and removing the clothes are important, but not as important as stabilizing the patient first. Hypokalemia can actually predispose a patient to digoxin toxicity because potassium and digoxin itself compete for the same site on the sodium-potassium ATPase pump. When you have less potassium, more digoxin becomes bound. Therefore, if your potassium levels begin to drop, say for example you're given Lasix, or there's a dietary issue, or you're having diarrhea, what will end up happening is your digoxin levels will begin to rise and bind more effectively and more quickly because there's less potassium around. How will a patient with digoxin toxicity present to you? They may present with visual disturbances such as yellow, halo vision. They may say they feel strange symptoms in the chest like palpitations. Remember, bradycardia, atrial tachycardia, AV block, ventricular tachycardia, and slow AFib are all very common rhythm disturbances with digoxin toxicity. The most common presentation of dig toxicity is gastrointestinal problems such as nausea, vomiting, and abdominal pain. They may have hyperkalemia from the inhibition of the sodium-potassium pump. And lastly, they may say nothing at all because they're confused. Now, one area with digoxin toxicity that is always a source of confusion, even for myself as a student, was the relationship between dig and potassium. Remember, hypokalemia will lead to digoxin toxicity. However, if you start out by taking too much digoxin, then you're going to end up getting hyperkalemic. The most accurate test for someone with digoxin toxicity is simply obtain a digoxin level. The best initial test, however, is a potassium level and EKG. The EKG will show downsloping of ST segments in all leads. Atrial tachycardia with variable AV block is, however, the most common dig toxicity arrhythmia. But remember, dig can produce any arrhythmia. Now here's an example of an EKG with dig toxicity. If you look at leads 1 and 2, you can actually see downsloping of the ST depression. It's also apparent in AVL and AVF. The best treatment for somebody with dig toxicity is to get control of the potassium level and then subsequently give digoxin-specific antibodies. Dig-binding antibodies actually remove digoxin from circulation. The strongest indication for giving these antibodies are CNS and cardiac involvement. That would be altered mental status, confusion, or some form of an arrhythmia. Our next form of poisoning comes with lead toxicity. Lead is diffusely toxic throughout many organs in the body. Patients will present with abdominal pain, or known as lead colic. They'll be hunched over in pain, and it waxes and wanes. They'll have memory loss and confusion. A lot of patients will say they just feel like pins and needles sensations, and some of them will have a peripheral neuropathy so bad they may even manifest a wrist drop. Sideroblastic anemia is the most common finding on their CBC profile, and many of them will develop acute tubular necrosis due to renal tubular toxicity. The best initial diagnostic test is an increased level of free erythrocyte protoporphyrin. The most accurate test, however, is a lead level. Remember, the most accurate test for sideroblastic anemia is a Prussian blue stain, not a lead level. Lead interferes with hemoglobin production and thus gives anemia. By getting a Prussian blue stain, you can actually see iron buildup in the red cell mitochondria. Chelating agents are the best choice for treating someone with lead poisoning. They actively remove lead from the body. Succimer is the only lead chelator that is oral. EDTA and BAL are parenteral. Mercury can poison the body through two routes. The first is through the oral route. Oral mercury ingestion can cause neurologic problems. The patients present with nervousness, they're jittery, they say they have twitches, and sometimes they even hallucinate. Inhaled mercury vapor actually produces lung toxicity, and the patients will present with signs and symptoms of interstitial fibrosis. There's no therapy to reverse the pulmonary toxicity from mercury poisoning. Chelating agents such as dimercaprol and Succimer are both effective in removing mercury from the body and decreasing neurologic toxicity. They can actually prevent progression of the pulmonary disease, but unfortunately cannot reverse the fibrosis. Alcohol in large amounts is toxic to the human body, but there are two forms of alcohol that are toxic at any quantity. These are methanol and ethylene glycol. These can produce intoxication, metabolic acidosis, an increased anion gap, and will also give you an osmolar gap. The way they're treated is with fomepizole and dialysis. The differences between methanol and ethylene glycol are striking. Methanol is found in wood alcohol, cleaning solutions, and paint thinner, while ethylene glycol is found in antifreeze. Methanol metabolizes to formic acid and formaldehyde, while ethylene glycol forms oxalic acid and oxalate. They present very differently. Methanol will present with ocular toxicity, while ethylene glycol presents with renal toxicity. The initial diagnostic abnormality that you will notice is with methanol, you'll find retinal inflammation, whereas with ethylene glycol, you'll find the classic envelope-shaped oxalate crystals in the urine and hypocalcemia. Now, as we said earlier, the toxic alcohols can give you an increased anion gap, but they can also give you an increased osmolar gap. The osmolar gap is the difference between the measured serum osmolality and the calculated osmolality. The formula is 2 times the sodium plus the BUN over 2.8 plus glucose divided by 18. Now, if you calculate the serum osmolality to be 300, but on measurement you find the osmolality to actually be 350, it is possible that a toxic alcohol, such as methanol or ethylene glycol, is accounting for these extra osmoles in the serum. Remember, ordinary alcohol, that is known as ethanol, also increases the osmolar gap. The best initial therapy is fomepizole. It inhibits alcohol dehydrogenase and prevents the production of the toxic metabolites. With methanol, that's formic acid. With ethylene glycol, that's oxalic acid. Remember, fomepizole does not actually remove the substances. Only dialysis can remove methanol and ethylene glycol from the circulation. Now we're going to move away from poisonous ingestions and start talking about snake bites. The most common injury from a snake bite is actually the local wound. 25 to 35% of the bites are not deep enough to actually deliver the venom to the bloodstream, but they do deposit the venom into the tissue. This venom has proteases and lipases that cause a local inflammation and local damage. How do snake bites then kill people? Well, they have two forms of toxins. The first is a hemolytic toxin, which causes hemolysis and DIC. The next is a neurotoxin that can result in respiratory paralysis, ptosis, dysphagia, and diplopia. Snakebite treatment falls into two categories, those that don't work and those that do. Applying a tourniquet and blocking arterial flow to the area of bite does not work. Applying local pressure does. Applying ice does not work. However, immobilizing decreases the movement of the venom from the bite into the periphery. Incision, suction, especially by someone else's mouth, is definitely not indicated. However, finding a local hospital or somebody with antivenom is the next best step. All spider bites present with a sudden, sharp pain. Your patient might tell you, "I felt like I stepped on a nail," or "Suddenly I felt like there's a piece of glass in my shoe." There's so many different spiders in the world, but the USMLE loves to test on the black widow and the brown recluse. On presentation, a black widow spider will present with abdominal pain and muscle pain, while a brown recluse will have local skin necrosis. On labs, a black widow will have hypocalcemia, while the bite of a brown recluse will cause no lab abnormalities. When it comes to treatment, the best treatment for a black widow spider bite is calcium, as the patient is already hypocalcemic, and to give the appropriate antivenom. Whereas for brown recluse spiders, notice there is no antivenom, but the treatment really is dapsone, steroids, and debridement of the bite. Dog, cats, and human bites, oh my. The good news on the USMLE is if a person is bitten by a dog, a cat, or another human, they're managed identically. They're treated with antibiotics, specifically amoxicillin combined with clovelinate. They're going to be given a tetanus vaccination booster if it's been more than 5 years since their last injection. And the bacterium that you need to know is Pasteurella multicida. This is the one that's given by dogs and cats. Remember, the humans pass on Eikenella corrodens. Remember, most importantly, that human bites are far more damaging than dog and cat bites. So be careful if you're studying with somebody who's really hungry. There are two major instances when a rabies vaccine is given. The first, if the animal had altered mental status or some bizarre behavior. And secondly, if the attack was unprovoked by the human. If it was a stray dog that cannot be observed or diagnosed, give the rabies vaccine. There's always the question, if a tree falls in the woods and there's nobody there to hear it, does it make a noise? In the same instance, if someone says they were asleep, but a bat was noted to be in the room, you must vaccinate the patient against rabies.